Yeah.
Okay. So, as everybody's seen and heard over the last week, obviously, the vaccines, the first of two vaccines that are likely to get approved for emergency use authorization has been approved, the Pfizer vaccine. I want to answer some questions today and also go over some common things that we've been hearing. For anyone who doesn't know me, I'm Dr. Dauphinais. I've been the medical director here for the last few years. I've been coming here for over 10 years. Lately, I've been sneaking in and out at different hours, so you may or may not have seen me a lot more recently. This is a really, really important time for everybody. I mean, we're all sitting here with our masks. You see me with my N95 mask on that I've myself, and I'm also a medical director for Optum. I've had every one of my clinicians wearing this for the last 2 months now because there's just been such a high rate of COVID. And I really wish I could tell you that the next month or two is going to be less, but chances are good across the board it's going to be more. It's going to take a long time to get people vaccinated, and we have to get a high percentage of everybody vaccinated, very high percent. And there's a few things I do want to go over. There's a lot of questions out there, and I want to take any questions people have today so we can help them out. So first thing about the vaccines, I've heard a lot that people are saying these are brand new, never been tested before, that the vaccines that have just been approved are new technology, and I want to go over that a little bit right at the start. So the technology for the vaccine is an mRNA vaccine. How many people know what mRNA is? You guys didn't have years of cellular and molecular biology and genetics? Really? Oh, man. mRNA is messenger RNA. RNA is a way that your body decides on signals to make proteins. So your DNA is what's in your cells, but the RNA is made either by your cells or it comes in other ways. And one of the ways that unfortunately it comes sometimes is viruses will make it, and then they'll use your cells to go ahead and make something. We have treatments that will use RNA, use messenger RNA. For the last 10 years, there have been cancer treatments that use mRNA as well. So these mRNA is basically, it's a messenger RNA. It's a messenger. So it's just a small snippet of information to help your own cells make a protein. In this case, what they've done is they've created the technology over the last 10 years it's been in use, and it's been studied for a good 15, 17 years. I don't know the exact amount, so anybody that's going to quote me on it, I'm sorry, I apologize. But what it does is they've been able to isolate part of the protein that's on what's called a spike protein, so part of the COVID molecule that's unique to the SARS coronavirus 2 virus. So coronaviruses are cold viruses. Let's start there. A coronavirus has been around for forever. There's different versions of coronavirus. You might have heard in the early 2000s of something called SARS. And then 2013 was MERS. And now we have SARS-CoV-2, these are all different coronaviruses that have changed from what we typically have in circulation as cold viruses, coronaviruses, and they've become more virulent. They are easier to catch, and they cause a little bit worse of an outcome. In this case, and in the SARS and the MERS, it's a bit worse. We've all seen that. We work in nursing home. We know how bad it can get. What the vaccine does, the mRNA vaccine, again, it creates a messenger. It's a messenger RNA. It's a small signal. So it's a little message that says, this is how you can make part of this protein. Not the virus, not even the whole protein, but a big enough part of the protein so that your body can then make antibodies. So this message goes in, your cells see it, and they say, okay, I'm going to make this part of the protein. then anytime you make mRNA in your body or from any other source, what your cell does is it says, okay, I've taken this message. Use a pen. I've looked at the message. This is a good message. I'm going to do what it says. I don't need the message anymore. And then I'm just going to get rid of it. Now, that probably has some HPI on it, so I've got to get rid of that in a second. So it doesn't keep the mRNA there. It doesn't stick around. And then it makes these portions of the protein so they can't do anything to you, but your body creates the antibodies to get rid of them. So you've gotten rid of the mRNA, and you've gotten rid of the proteins, but you're left with the antibodies. And these antibodies can then go ahead, and when they see this section of message, and to use an example, if you look for a message in a book, if you look for the word "the," how many times do you think you're going to find it in the book? A whole lot. Over 100, probably on a page. But if you look for the exact phrase, the big brown dog ran away quickly from the orange child. I don't know why I came up with the orange child, but I did. But if you look for that exact message, chances are good you're only going to find it in a very specific spot. So you make enough of a message so that you recognize something unique just to that spike protein. And that's what they're designed to do. And the reason I bring that up is because there's a circulating theory out there that this mRNA vaccine creates a protein, part of the protein of the SARS coronavirus 2, that goes ahead and overlaps with a portion on the placenta. So there's a theory going on that it can lead to infertility. So that's just a very small part. So that would be like if you were saying, okay, I want an antibody to just the. You're not creating that. You're not looking for just that one part. So you have that little part circulating, but you don't have the whole message. You don't have the whole portion of the protein that you need to have. So that theory that says, because it overlaps with this, called a SYN-CIST1, where it's called an epitope, which is a portion of a gene. That part of the particular protein on the placenta, it's a small portion. In fact, this happens all the time. There are lots of cold viruses, as we've mentioned already. So there's some overlap that already exists. And if that was the case, if any woman ever caught a cold, she'd be infertile and never have kids. And I know lots of women who've had colds while they were pregnant and got pregnant after having a cold. So that theory that's about infertility really is one that it makes you think, but then you have to come back to, how does this really work? What is the biologic plausibility? What is the likelihood that this can actually be an issue? So when we look at that, we say, okay, if we look at how this works, we look at how this is made, we can say there's a good chance that this really isn't the case. So we can help put that aside a little bit. When you say, well, this is brand new, this hasn't happened, and we've already mentioned that this technique's been around for a long time, it just happens that at the same time that the virus is coming up, we have this technique that's been used for a long time. They've been planning on using it for making vaccines, but there's something that always is missing. Let's see. What do you think's always missing it when you have to manufacture something big and new?
Money.
People and money. So, people, how many people in the world do you think are interested in this at once?
Everyone.
Pretty much the whole world. So you got an entire world. You got all the countries in the world. So you have people and you have money already ponying up right off the bat. The other part of people is, in order to study anything enough, you need enough people. Now, the FDA has very, very good safety protocols in place and says that to be able to get enough information, you need a minimum of 3,000 people. So how many people think that you had at least 3,000 people that were involved with this studies? Pfizer trial had over 40,000, and the Moderna trial had over 25,000. So anyone who says, I don't want to be the first person, I don't want to be the guinea pig,
I will.
Even before that.
I'll be the.
Thank you for volunteering. You could have been in the trial. Johnson & Johnson has a trial going on right now. But for the Pfizer vaccine, the Moderna vaccine, which is hopefully going to get emergency use authorization this week, they've already had 40,000 and 25,000 people go through trials with this. So what are side effects that people have? You've had the trials. Do we know they're safe? Well, so far they've been shown to be safe in the time frame of the trials. What was the time frame? Minimum of 2 months. We've seen in all of the vaccine trials, we've seen at least by far the majority of all side effects occur in the first 6 weeks. Most occur within the first couple days to 7 days. But almost all side effects are in the first 6 weeks. They went out to at least 8 weeks for these 40,000 or these 25,000 people in the studies. So they've already monitored it for that amount of time. And what if they find for side effects? Most common side effects, I'll tell you right now, expect your arm to hurt a little bit for a couple days. People that I heard yesterday getting the vaccine, they were saying, "Oh, it's great, my arm doesn't hurt." Well, I remember getting Tdap. Has anyone ever had their Tdap? Mm-hmm. First day, not too bad. A day later, I'm doing the yard work, and I'm saying, "Why is this bothering me so much?" I'd only warned about 1,000 other people before that you're going to have pain in your arm after a Tdap or after the shingles vaccine, Shingrix. Shingrix is the one that bothers people the most. I don't know how it compares yet to Shingrix, but it does, in many people, will cause some discomfort in the arm. Mild flu-like or COVID-like symptoms. This is going to be the tough one. Usually within the first 48 hours. Could be a low-grade temp, just feeling a little run down. That's happened in a number of people. More commonly after the second dose, and we'll get into 2 doses in a minute, but more commonly after the second dose than after the first dose. So most people in the first dose don't really have much of an issue. At the second dose, there's a number of people, and I don't remember the amount, that will have one of these types of side effects. Then you've got all your standards that every provider, every physician, APRN will rattle off to you. Well, the risk of cough, mild fever, nausea, vomiting, diarrhea, very minimal on those. Most common are the ones we just mentioned. And I'm sure you've heard about in the first 24 hours of this going in the United Kingdom, everyone already heard that there were 2 people that had severe allergic reactions. These were people who were known to have severe allergies already. They already carried epinephrine pens with them, so they knew they had to be ready that they could easily get a severe allergic reaction. So in that case, if you have a history of significant allergies, what does that mean? That means anaphylaxis. It means that you've had an allergic reaction where your face is swollen, that your lips have swollen, you started having trouble breathing. That's when you need to talk to your doctor first before getting a vaccine like this. But otherwise, this is approved for anyone 16, I believe 16, definitely 18 and above. And it's highly recommended for people that are higher risk conditions and people who work in a healthcare setting, especially long-term care setting like this. Because we're the ones that have seen it. We're the ones that are in contact with people that are most vulnerable. And it will really make a difference if we can go ahead and have people getting the vaccine. This is how you build up your antibodies. There's a question as to, well, what if I had COVID? Or one of my favorites was, well, I've been around it all the time. I either had it or I'm not going to get it because I've been around it a lot. We don't know the length of time of this virus. The length of time that you have antibodies to it, the length of time you develop immunity to it. Has anyone in here ever had a cold virus more than once? Anyone ever I've been unfortunate enough to have the flu more than once. Get your flu vaccines. The viruses, especially this family of virus, unfortunately you can end up getting more than once as the antibodies wane, as your immunity wanes. We have seen that in some people. So we're trying to track how much it occurs, but we have seen it in people throughout the country. It's not super common, fortunately, but it does happen. So we don't know how long it's going to last. We think majority of people up to 90 days. So you say, well, I had it 60 days ago. The challenge here is we don't know if or when, what the timing is going to be, how many vaccines are going to be available, in what capacity when. So if the opportunity comes up, this is when we should be taking it. We should be taking it now, unless someone actively has COVID-19. So if someone actively has it or was diagnosed within the previous 2 weeks, then no, they shouldn't get it. But everybody else, we would highly recommend it. Pregnant women haven't been studied yet. There's a reason for that. In this country especially, the standard of care is that you make sure you've gone through all the different safety studies first before you come to pregnant women, studying pregnant women and studying in kids. We do have people who became pregnant when they were on the initial trials, and they all did fine. But there wasn't enough to be able to say without any doubt there could possibly be any issues. So even though the data suggests that it's not an issue, the biological plausibility, meaning the likelihood based upon the biology, doesn't suggest there would be any issues. We're a little more cautious with the statements for women who are pregnant, and the recommendation is if you're pregnant or planning to get pregnant, then you should be talking to your doctor about it. I will tell you there are differences of opinion based upon the doctors that you go to. Imagine that, right? Two different viewpoints from two different doctors. How does that happen? Some have the information, some don't. So we have to go back again to what's the biologic plausibility, what's the likelihood, what's the reality that it can occur, and what have we really seen. So with that, I'd like to ask any questions in particular. It can definitely be about a friend. It doesn't have to be anything specific to you. But I'd certainly like to hear what everybody thinks, what everyone's concerned about, because this is important. This will make a big difference if we can get people vaccinated. It's amazing that's happened. Of all the things that have not gone great in the last year, one thing that has been amazing and great is how many people all throughout the world have come together, have really worked hard on doing things like this. Not just the FDA, the CDC, the World Health Organization, but there's groups all throughout. I've never been in a situation before where I've talked to so many people throughout the country about what they're finding, what they're seeing, what they're doing. How can we do this? How can we change this? At the start of this, everybody here, everybody in this room, I want to say thank you for everything everyone did here. I was on the phone with Alex and Josh almost every day for about a month and a half straight. Alex was so sick of talking to me. She's like, I'm trying to finally get a half a day off. Please stop. But everybody here came together. Kept trying to make sure that our residents were getting to see their families any way they could, either through windows or through FaceTime, looking out for each other, pulling things together, bringing things to residents in their rooms. So thank you. That was inspiring. That's why I've stayed in long-term care instead of staying in an office or staying in a corporate rental. So thank you. That's just deeply inspiring, and I wanted everybody to know that I saw that, and I'm going to stop there. So thank you. So we have questions.
How long do you think the antibody is going to last for?
The vaccine, yeah. So immunity from the vaccine is likely to last 1 to a couple years. Not likely to be lifelong. Whether or not we need boosters in 1 year, 2 years, 3 years, 5 years, or never again, we don't know yet. A lot will depend on how many people actually get vaccinated, how well we do over the next 6 months with continuing to distance and use masks, because over the next 6 months especially, we're still going to need to do that. So I think there'll be a good amount. I think it'll be personally a couple of years, like a 2 to 3 year thing based upon what we've seen. I'm hopeful that we do such a good job that it's so minimal in the community that in 2 years we'll be trying to figure out, well, is there really any chance it could be anything related to this? And that brings us back to the why 2 doses, why 2 injections. The first injection after 7 days produces about a 52% efficacy, meaning half the people who would have gotten the virus just by regular risk of exposure didn't get it. So let's say normally out of 10,000 people, 100 people would get it just from day-to-day life, doing everything exactly the same. The people who got 1 dose of the vaccine, only 50 got it. That's helpful, but it's not great. It doesn't protect all of us. But if you get 2 after 3 weeks, so a week to 2 weeks after a second dose, given 3 weeks after the first dose, now we're up to 95% efficacy, meaning if normally 100 people would get sick, only 5 would. So that's a big, big difference. And the better part is, of those people who got sick, who had gotten the vaccine, in the studies, essentially none of them had bad outcomes, meaning none of them got severely sick. None of them ended up in the ICU for weeks on end, and none of them ended up dying. I can't say 100% no. I'd have to go back through the data again. But it was, the relative amount was so staggeringly different that essentially we can say that. So, very good question. Appreciate it. Thank you. Other questions?
As far as your immune system, how strong does that have to be?
How strong does the immune system have to be? So, like a lot of things, your immune response has to do with how good your immune system is. So when you give something, any type of vaccine that is designed to stimulate the immune system, it's going to work better in those with a strong immune response. So there's pluses and minuses to that. The plus side is that when you get the vaccine, your risk of going ahead and having more of a reaction is actually lower if you have a less of an immune response. The other plus is that we're doing two injections to really stimulate the immune response. So we work with elderly individuals. The reason we give a high-dose vaccine to individuals who are older is because that stimulates the immune response more. So somebody who's older, who has less of an immune response in general, we know that if we give them a higher dose. So we're covering it pretty well. There might not be as much of an immune response, but there still should be some. On the positive note, from an infection standpoint, there is some theory, we don't know exactly, some theory that individuals that don't amount as much of a response, the latter part of the actual infection, the most damaging part of this infection actually is not the virus itself. While the virus is replicating, yeah, you feel horrible, you feel sick, you don't do so well, your body's trying to fight it off. But most of the people that do really bad are the ones who have what we call a hyperinflammatory response, meaning that their body keeps overreacting, and you literally are attacking yourself with that overreaction of not the antibodies, but other inflammatory processes that are designed to help get you better, but it gets overstimulated with this virus. So we've got things we've got to watch out for. You can amount to response. We don't, as a correlate of that question, the people that got antibodies from the monoclonal antibodies, we don't know what their immunity is to this. So someone who says, well, I got the antibodies given to me, that's great. We don't know how long an external antibody is going to last. It's probably going to be a lot less than your own natural antibodies that you're going to develop. So even in those cases, we do want people to get the vaccine at this point. So I think that's important. And it's important to know for all of us. I will say one of the decisions I had to make for getting somebody monoclonal antibodies was made in part because that person had a lower immune response in general. They were immune deficient. And that person did quite well. So that may be a case if someone has challenges with their immune response, they may get the vaccine, and they still may be candidates later on if they ever do get sick to get the monoclonal antibodies at that point. Other questions?
When are we gonna start getting it? And I wanted to, this is for you guys. I talked to a lot of people today and they're not here. They're the ones that, oh, I'm not taking the shot, I'm not gonna take the vaccine, I'm not gonna do this. They're the ones that should be here. So maybe we can do a blast where if you have any questions or any doubts, you guys are the ones that should be here, you know?
Are we
So-
recording today?
So we're recording, the residents are all watching it as we speak on their TVs, and the video will be blasted out
Oh, good,
to all of you guys, and Dr. G's gonna come back again
great,
tomorrow.
Tomorrow.
I think.
Hopefully before the storm.
So when are we gonna start with the vaccines?
I don't have a
You-
date, but we are, in talks with Walgreens.
So
We should know
every
by
facility, and at least in Connecticut, has been assigned to either Walgreens or CVS. Walgreens and CVS is going to give every single facility 3 dates. So to get 2 vaccines. So you have to be able to be getting your first. Ideally, you get it on your first injection with the first go around. If not, there is a second date that you can do it. But if you miss those first 2, it's going to be really hard to be able to get the vaccination series because they're only in the first go around. They're only giving 3 dates. The nursing homes in general in Connecticut are starting to get vaccinated as early in some cases as next week, but it depends on the facility. So Josh and Alex are in conversation with Walgreens right now, working on coordinating the dates and trying to make sure we give everybody some time. You're not going to, there's unfortunately not specifically that they expect that they're going to be doing a lot of nasal swabs in the week after the vaccination. And I expect we will too. It's just, we'll still want to check, we'll still want to figure it out. Josh, Alex, and I are going to be talking a bit about what we're going to have to do for a protocol because we're going to be trying to vaccinate a lot of people all at once. And we can't all of a sudden have everybody with symptoms and saying, okay, you're all out of work. It'd be nice for all of us to take one big happy holiday together. But we've got a responsibility here. We've got people to take care of. So we'll figure that part out. But I'm expecting that we'll be doing a fair number of swabs a week or 2 afterwards. Did I answer the question fully?
Yeah, thank you.
Yeah, I know. I'm getting
Trying
shot.
to block you.
You're trying to block the sunlight on me? Should have brought my sunglasses. I'm going to come over this way. I can still be seen there. There we go.
So you said we still have to get tested after we get the vaccine for a while?
So there'll be a time frame to still get tested.
Okay.
We don't know when that is.
Okay.
And that's going to depend on a lot of factors, and the state's going to help us figure that part out. So more to tell. The good news is, if we get everybody vaccinated, that time frame that you need to keep getting tested is going to be a lot shorter than if we don't. If we don't do this, guess what? Our noses are going to get that stuff up there every week, and I do it too. I walk in every week. I walk in on Wednesday, grab my little vial, grab my thing. Shove up both nostrils, go from there. But that'll go away a lot faster after this.
Sorry, I have a lot of questions. So, if you're saying that the people who get the vaccine could still be carriers, even though they're not having the active virus, does that make it worse off for the people who don't get the vaccine around them?
It won't make it worse, but it'll still be in the same situation we are now.
The same. Okay.
So anyone who thinks the idea of, well, we'll just generate herd immunity with everybody else, not with me, I won't do my part, actually puts that person it does put them at higher risk. Because it's just like it is now. And this is, I'm gonna let the pet peeve of mine go on video here, is individuals that go around and say, well, I don't feel bad, I don't need to wear a mask, I'm young, I'm not going to get too sick, it's my freedom. You're right, it's your freedom to decide about wearing a mask or not. Absolutely. But it is not your freedom to become a biologic weapon to give me something that could potentially kill me, because we don't know.
Amen.
I have medical directors, I have physicians, I have APRNs, I have nurses, I have I have workers. There's been a lot of people who do the brunt of the work, like CNAs and our housekeepers and our kitchen workers, who have died from this thing because they got it from somebody who didn't even know they had it. So you're a biologic weapon without even knowing it. So in a lot of cases, we call that terrorism. So I'm sorry, I try to be apolitical on camera. I don't consider it political. I consider it just general public health. So this is something that if somebody avoids it, they're doing themselves harm, because the rest of us are doing what we need to do to try to help that out. Now, I won't say that there aren't reasons for people not to get the vaccine. There's definitely are reasons. We've already mentioned severe allergies. We don't know for pregnant women, so we're going to be cautious there. People who have had bad reactions to vaccines in the past, those are people that should be monitored. There's no signs of issues with Guillain-Barré with this, like we've had in some other things in the past. None of those types of issues. So, and I know it's concerning for people because it seems new. But all the times we've ever had something come out, this is extremely well studied. This has had lots of people take it beforehand. We are still going to be learning. I am not going to give you information that I don't feel very strongly is true and well supported. So I'll let you know. I have personal reasons for being very interested in the fertility question. I don't think any person should ever have to question why they had any issues with fertility. Did I do something? I've seen how that wrecks the lives of family members. It's just horrendous. So I wouldn't misrepresent to anybody with that. So it's 5 of 3. I apologize. I do have to go. I am going to make myself available for questions or calls. So certainly run them up through Josh and Alex. Let them know. And we'll have the informational sheets available for everybody too. Thank you, everybody.